Okay, thank you. A very good morning, everyone, and thank you so much for attending this symposium this morning. My name is Nilofar Noor, and I am the Advanced Laparoscopy ATSM trainee at Derby Endometriosis Center, and I'll be giving a brief overview about endometriosis today. So endometriosis is defined as presence of endometrium-like epithelium and or stroma outside the endometrium and myometrium. So when it is inside the myometrium, it is adenomyosis, and often this condition is associated with an inflammatory process. It's found to be present in about 1 in every 10 women, so 10% of general population, but in women with subfertility, it may be seen in up to 50%. And about 190 million women worldwide have been shown to be suffering from endometriosis. The hallmark of endometriosis in terms of symptoms are pain and subfertility. Pain can be clinical or non-clinical, or cyclical or non-cyclical. There may be dysmenorrhea, deep dyspareunia, or chronic pelvic pain. And if there's involvement of bladder or bowel, there can be dysuria or dyschezia. And in case of diaphragm involvement, there can be shoulder tip pain. In case of scar endometriosis, there may be cyclical scars, swelling, and pain. Apart from this, other symptoms include fatigue, hematuria, painful rectal bleeding. In case of lung endometriosis, there can be cyclical cough, hemoptysis, chest pain, catamenial pneumothorax. Subfertility, psychosexual health, and mental health concerns are other symptoms that are associated with this condition. On examination, we can see on speculum examination vaginal nodules that are seen on in these pictures. On bimanual, we can elicit an adnexal tenderness. Endometriomas can be palpated as adnexal cysts, and often deep nodules, uterosacral nodules, may be felt. Endometriosis has a significant impact on the individual, but also on the society at large. And this occurs over the course of her life. So pain can result in limiting her functional ability, her physical functioning. It can force her to take time off school, time off work, which in turn affects her productivity and her life choices, career choices. Dyspareunia and subfertility can have a significant impact on relationships, can be associated with anxiety and mental health concerns. And eventually, all of this can have a significant impact on healthcare costs and have an economic burden on the society. It is the second most common gynecological condition in the UK, and it costs about 8.2 billion per year to the UK economy for the treatment, and when you take into account the loss of work and the healthcare costs. And it's been suggested that about 11 hours of work per week are lost because of endometriosis. Despite this, there is a significant diagnostic delay from the onset of symptoms to the establishment of a diagnosis, and it can range between 8 to 12 years. And about 60% of these women will see 3 or more clinicians before a diagnosis is established. And one of the other things which is still much talked about and much researched about is the etopathogenesis behind this disease, which is not very clear still. But several theories have been postulated, and I'll just touch upon the most common ones. So retrograde menstruation theory was given by John Sampson in 1927 and has long been a widely accepted theory. And it basically suggests that during menstruation, there is retrograde flow of endometrial cells and stroma through the fallopian tubes into the peritoneal cavity, where they then get implanted and then go on to become endometriotic lesions. It does explain the common superficial sites of peritoneal of endometriosis, such as the tube, the ovary, the POD, the pelvic wall, pelvic peritoneum. And it also explains some of the risk factors that are associated with endometriosis, which I'll talk about more later. However, it does not explain deep endometriosis outside the peritoneal cavity, endometriosis reported in women who do not have a functional uterus, in young adolescents, and even in newborns, and rare cases of male endometriosis. Another theory, which is the coelomic metaplasia theory, was given by P. Grunewald in 1942, and and he suggested that coelomic walls, which also make up the peritoneal serosa and serosa-like structures, are embryologically related to the Mullerian ducts, and therefore, when a trigger or a stimulus occurs, especially estrogenic stimulus, then these coelomic wall derivatives can undergo metaplasia and form endometriotic lesions. The hematogenous and lymphatic spread theory suggests that endometrial cells and stroma disseminate via the lymphatics and the blood vessels, and they then get embedded into distant organs and form endometriotic tissues. However, it needs to be established that these cells can actually pass through the angiolymphatic circulation and undergo extravasation and get embedded into the tissues without disruption. Stem cell recruitment theory says that stem cells can get into various anatomical sites and differentiate into endometriotic lesion. And there are two theories regarding origin of these stem cells. One is stem cells arising from an uterine endometrium, and it is thought that this is usually present at the junction of endometrium and myometrium, and it is normally involved in regeneration of the endometrium uh, upon estrogenic input. And during retrograde menstruation, these stem cells travel into the peritoneal cavity, get implanted, and then become endometriotic lesion. Another source of stem cells can be bone marrow, and stem cells from the bone marrow get disseminated into soft tissues and then become endometriotic lesion upon estrogenic stimulation. And people have suggested that maybe male endometriosis, that could be a mechanism behind that. Embryogenetic theory is suggests that during the embryonic embryogenesis and the migration of Mullerian duct from being an abdominal structure to a pelvic structure, some residual persistent embryonic cells may get lost along the pathway and persist along the pathway. And later on, when puberty occurs and there is increased estrogen, these then develop into endometriotic cells. And this perhaps can explain the presence of endometriosis commonly in the deep peritoneum and the pouch of Douglas, which is the migratory pathway. Coming to the risk factors, uh, uh, early menarche, short menstrual cycle, heavy menstrual bleeding, and obstructive genital malformations. They are all basically risk factors, and which may be because the more a woman bleeds, the more frequent she bleeds, the earlier and the longer she starts bleeding. And all of these are associated with more chances of there being retrograde menstruation and a more amount of blood entering into the peritoneal cavity and therefore resulting in endometriosis. Another important risk factor is family history. And especially when adolescent girls present with symptoms of chronic pain and have a strong family history, then endometriosis should be considered in these adolescent girls. Coming to classification of endometriosis, now over 22 classifications have been suggested, and the aim behind classification, any sort of classification, would normally be to map the disease, to create a surgical plan, to anticipate the length of the surgery, anticipate complications, and then therefore have involvement from other specialties to predict the fertility outcome, and most importantly, to counsel the patients. But I will talk about a few common classifications that are used for this condition. The one of them being revised ASRM classification, which is given by American Society for Reproductive Medicine. And this classification looks at the operative finding of these women, either laparoscopy or laparotomy, and based on the extent of the disease that is visible on the peritoneum, on the ovary, on the pouch of Douglas, and on the tube, it scores. Gives a score, and based on the score, the disease is then classified into stage 1 to 4, ranging from minimal, mild, moderate, and severe. The problem with this classification is that it does not classify the deep endometriosis. And also, the stage or the severity of the classification may not necessarily correlate with the symptoms. So somebody with minimal endometriosis, as per the classification, may be very symptomatic with pain and subfertility, whereas somebody with more advanced type of endometriosis, as per the classification, may not be as symptomatic. In addition, it does not give any idea about the fertility outcome as well. So to deal with this, there was an enzyme classification that was suggested to talk about the deep endometriosis. It divides the deep tissues into 3 compartments, essentially. So A is the rectovaginal space, the vaginal and the retrocervical area. And B is the lateral spaces, so the sacrouterine ligaments, cardinal ligaments, and the pelvic side wall. Whereas C is the rectum, and depending on the size of the lesion, these are then classified into 1 to 3. All other organ involvements are classified under F, which is for foreign, and depending on the organ involvement, they are then used over there. The interesting thing about this classification is that this can be done preoperatively using imaging techniques like ultrasound and MRI as well. But again, since it did not look at the ovaries and tubes and other structures, a revised enzyme classification has more recently been suggested, which does take this into consideration as well. Finally, the endometriosis fertility index, or the EFI score, is a frequently used score, especially to predict the fertility outcome in these women, and it takes historical factors as well as surgical factors into consideration. Historical factors include age of the women, number of years of infertility, and evidence of prior pregnancy. Whereas the surgical factors include the least function score, which basically looks at the function of the tube and the ovary, and higher the score, better the function. And it also looks at the ASRM classification that we discussed earlier, and also looks at the total score of these 2 surgical factors. It then sums up the historical and the surgical factor and gives the final EFI score. And it has been suggested that when we look at these women over 36 months, or about 3 years, women who have EFI score of about 9 to 10 have 80% chance of spontaneous conception, whereas those between 0 to 3 have about 10% chance. So the score between 0 to 10, and more recent studies have shown that when the score is over 5, then these women can be given a couple of years to attempt for natural conception, whereas when it is less than 5, it is usually recommended to refer them for assisted reproduction. Thank you very much.
Can you hear me?
Yes.
Hi. Can everybody hear me clearly?
Yes, we can hear you.
Yes.
That's a good start,
Thank
Nilofar.
you. Thank you very much.
So time for some questions.
Nilofar, I think just, I'm not sure if the mic is still working or not. You can, but can everybody else hear me?
Yes.
Yes.
Oh, all right. Okay. Thank you. All right, brilliant. No, thank you so much, Nilofar, for that. Sorry, even though we, sort of sorted out all the nooks and crannies and creases, but still we're having a bit of an issue, as we do all the time. Yes, any questions, anybody, in terms of the pathogenesis and anything that Dr. Noor has presented? Let's have a look at our chat box. No. All right. Thank you so much, Nilofar. I think then what we can do is go on to the next presentation, which essentially is mine. Yeah, I'll just start sharing my screen now.